Well, good morning, everyone. I would like to introduce someone who needs no introduction. And what I was trying to find was the recent announcement about Dr. Little. And I'm seeing if I can find it because I wanted to do the announcement. But maybe she will just share her very exciting new role before she talks about HIV prevention from CROI. But this is going to be, yeah, this is a well-attended high rounds today because I'm sure everyone wants to hear the summary of what happened at CROI on the HIV prevention stage, which Dr. Little will present. But I would love it, Dr. Little, if you could share with the group the new role that you were just recently given, and then we can go from there.
Sure. So thank you very much. So yes, I'm the director of the Office of Clinical Research for Health Sciences. So trying to improve, in case you're reading the news from yesterday, our compliance and safety for everyone involved in doing clinical trials at UCSD in health sciences.
So very exciting role, and we're very happy that obviously Susan will be doing this. So anyway, Susan, I will turn it over to you. I will moderate and only interrupt you if it's important. Otherwise, we'll save some time for questions at the end.
Okay. And a 10-minute or 5-minute warning would be much appreciated because I have a lot.
I will give you an 8:45 warning, and then we can go.
Perfect. Thank you. So welcome everybody. So this is a review of CROI 2024 focused on HIV prevention. And as stated in the title, there were lots of other things that were prevention focused, but I really did generally focus on HIV. So, and by way of introduction, not a single one of these slides is mine. So I'm trying to give credit for everyone as we move forward. So I'm going to start with Doxy PEP. And there were, again, a handful of studies, which I thought several of them were worth reviewing because they came to slightly different conclusions, but Doxy PEP, I think, is here to stay. So this is the final result of the ANRS DoxyVac, which is the title shown. So doxycycline post-exposure prophylaxis, Doxy PEP, has reduced bacterial STI incidence at the time now of 2 randomized trials in MSM and transgender women using HIV PrEP or living with HIV. This study included the use of the meningococcal B vaccine, which has been associated with a 26 to 46% reduction in gonorrhea, but only an observational study. So this was hopefully a definitive study to look at the effect of this vaccine. So 4CMB, the vaccine contains these OMV surface proteins, or proteins, I should say, shared with Neisseria gonorrhea, with 44 to 99% genetic homology, but the NHBA protein is the only one that is surface expressed. So that's why it is so relevant. And it contains 69% homology between the vaccine and this surface protein for gonorrhea. The hope is that that would be the mechanism by which it would be effective. And the preliminary results of ANRS DoxyVac were presented last year. Those were the interim results, and today this is the final result. So multi-center 2x2 factorial RCT, open label. So MSM on PrEP for at least 6 months with a bacterial STI in the prior 12 months, but no current STI symptoms, were randomized 2-to-1 to Doxy PEP, taken 24 to 72 hours post-sex versus no PEP, and then subsequently factorial design randomized again to the 4CMB vaccine, 2 injections, month 0 and 2. So the evaluation of the vaccine component starts at month 3, 1 month after the second dose. Again, the goal, the 2 primary endpoints, the impact of Doxy PEP on time to first episode of syphilis or gonorrhea, and then the impact of this vaccine on time to first episode of gonorrhea. That's really it. So looking here at the cohort, the total really is over on the right. They're well balanced. This is a French-born population. PrEP use, where's my pointer? PrEP use right here. month 33 is the mean, so median. So this is a well experienced. Worth mentioning, at least 2 STIs in the prior 12 months. And this is notable because, again, we're going to talk about the efficacy of these interventions for gonorrhea. This is a population where 68% had an episode of gonorrhea in the prior 12 months. So a very high risk population. Condomless sex high, partners 10 in the last 3 months, chemsex, etc. So this is the primary outcome for time to first chlamydia or syphilis infection. And you can see here nearly based on the adjusted hazard ratio, doxy-PEP is in blue. So a lower cumulative probability of first STI diagnosis by about 83%. And this is very similar to the interim analysis over here, adjusted hazard ratio, again, 84. So very similar outcome. This, however, is the time to first episode of gonorrhea. So this is the meningitis vaccine outcome. And again, endpoints start to be assessed here at 3 months. And what you can see here is that there was no, I guess this was a 33% reduction in the time to first gonorrhea event, but that was markedly less than the interim analysis, which had been much closer to 50%. So disappointing. And then let me go back. Hold on once. Oh, stop. Yeah, doxy. Okay, sorry, I thought I missed one. And then here, again, this is, there was just the finding, there was no interaction between doxy-PEP and the 4CMV vaccine. And again, this was the interim analysis showing about a 50%, but the final analysis was quite a bit lower. You can see these are essentially superimposable. So, I skipped a lot of the data for many of these studies, but I'm going to present just the summary, which reviews some of the data not presented. So now 3 large studies have shown a strong reduction in chlamydia and syphilis among MSM and transgender women, much less effective against gonorrhea with an increased rate of high-level resistance to tetracyclines, suggesting that effectiveness may wane over time. So not shown 100% of the participants, keep in mind Europe has a high rate of gonorrhea resistance to tetracyclines, and 100% of this population was resistant at baseline, with an increase in high-level resistance over the duration of the study. So there is clearly some concern about the use of doxy-PEP and the evolution of gonorrhea resistance. And in Europe, they're starting with a very high baseline. So doxy-PEP, however, was well tolerated, adherence was high, and again, implementation studies are underway to monitor the antibiotic resistance, which I think is really the one remaining concern. The effectiveness of the vaccine on gonorrhea. The data in this final analysis were thought to be inconclusive, but they said you can't rule out a small benefit. However, the clinical relevance seems pretty limited. There were very similar rates, again, data I didn't show, of cumulative infections, symptomatic infections, and culture positive infections. So again, additional phase 3 trial data awaiting, but the vaccine effect on gonorrhea was, I would just say, pretty disappointing. So jumping next to Annie Leuchtemeyer's study, again, the doxy-PEP open label extension. So this study has already been published, New England Journal last year sometime, and now this is the open label extension of this study. So just to remind, this is, again, open label doxy, 200 milligrams as PEP within 72 hours after condomless sex with a max of 200 milligrams daily. Similar population, MSM and transgender women, however, either living with HIV or without HIV on PrEP. The last study was 100% PrEP folks. They were 2-to-1 randomized to doxy-PEP or no PEP, and then followed with monthly evaluations and STI testing, or monthly, Q3 months, sorry. So the doxy-PEP results, again, published, overall 65% reduction in bacterial STIs each quarter with a roughly 80% reduction of chlamydia and syphilis, 50% reduction of gonorrhea. So that was, again, similar to the interim analysis of the previous study. And the effectiveness was independent of HIV serostatus. So again, picture worth 1,000 words. Probability of an STI much higher in folks on the standard of care arm compared to the doxy-PEP arm. So this is the open label extension. So May 2022, the DSMB pre-specified interim efficacy stopping rule, and enrollment was stopped and participants were notified of the study results. They then entered this open label extension, and participants who were originally randomized to standard of care were offered open label doxy-PEP, and then all participants continued for the remaining 12 months follow-up in study. And the objective here was to assess doxy-PEP effectiveness, its use and changes in sexual behavior in the setting of awareness of the efficacy of doxy-PEP, so the parent study. And then to compare the open label extension quarters to as randomized quarters for incident STIs, doxy-PEP use, and sexual behavior. They excluded quarters for standard of care participants in which doxy-PEP was not offered for the entire quarter, just to make the analysis cleaner. And then all comparisons were observational. So this study was not, it's an open label extension. It was not powered for a statistical comparison between the two arms. So this is the patient characteristics, just to remind everybody, well-balanced, age, race, cisgender men living with HIV. So relatively well-balanced across the two arms. But just to sort of highlight, this is a population with a relatively high level of sexual behavior. So in the last 3 months median, 9 sex partners in the primary randomized cohort, as compared to a bit higher in the open label extension, 11, roughly the same in assertive sex acts, receptive sex acts a bit higher, and again, group sex acts a bit higher in the open label extension cohort at the time of enrollment. So this is, again, the primary outcome as randomized quarters. You can see that the doxy-PEP arm had a 12% reduction in STIs and 31% presence, I should say, of at least one STI in the standard of care arm. Then in the breakdown by STI, so this is the same data you just saw. So this is the open label extension. This is the primary analysis on the left. And you can see the bulk of these are gonorrhea, followed by chlamydia, syphilis, and then greater than or equal to 2 STIs. And again, we're going to focus on the gonorrhea as we discuss this. So again, the prevalence of gonorrhea as the primary STI is notable. So again, this is the open label extension. People who were initially as randomized to doxy-PEP in the open label extension preserved reduction in bacterial STIs. And then folks who received no doxy-PEP and then were offered a change to doxy-PEP had a very significant reduction in overall STIs. Again, not quite as impressive as the doxy-PEP arm, though, again, not statistically evaluated. So the average doxy-PEP usage in, again, the as randomized, the original study, the standard of care arm had no doxy-PEP, and then the doxy-PEP randomized cohort had about 5 doses per month. And they just kind of wanted to highlight here that in both groups, the sexual behavior increased, as did appropriately the doxy-PEP doses per month. So both had an average of 6 doses per month in the open label extension. So modest increase in the reported number of doses in both arms, wide range of dosing frequencies reported. And again, going back to the as randomized, well, this comparison between the number of sex acts in the doxy-PEP versus standard of care, but really the kind of focus here is looking at the comparison between sex partners per quarter in the doxy-PEP arm during the randomized study component, and then increase during the open label extension. So this is true across every metric, sex partners per quarter, condomless insertive, condomless receptive acts per quarter. And then the same is true for the standard of care arm, but to a greater degree. So there was a doubling of condomless insertive sex in the from the standard of care arm that then rolled on to the open label extension with DoxyPep, doubling in the condomless receptive and doubling in the insertive and receptive sex. So sexual partners and condomless sex increased during the open label extension in both groups, but doubled in the standard of care arm that then moved over into the DoxyPep. Coverage, however, remained high, which was excellent, greater than 75% during the open label extension, and that was comparable to the DoxyPep as randomized. So the good news is increase in sexual behavior was matched with increased use of DoxyPep, so for very high coverage. So conclusions: in the setting of known effectiveness of the DoxyPep trial, DoxyPep was associated with sustained decreased STI incidence despite increases in sexual partners, condomless sex during the open label extension. And this supports existing now DoxyPep CDC draft guidelines, A1, which is the highest level, meaning randomized controlled trial supported recommendation. However, longer term evaluation of DoxyPep use under real world conditions is needed to understand effectiveness, sustained sexual behavior changes, and potential impact on antimicrobial resistance. And all of those strongly support. But the next study under real world conditions. So this next study I thought was really very impressive. So this is DoxyPep real world, and Hyman Scott led this effort from the San Francisco Department of Public Health. There we go. So San Francisco Department of Public Health recommended DoxyPep following the CDC recommendations in October of 2022. This was the health update posted in San Francisco. Reduces incidence of sexually transmitted infections. So the public health department focused on the Magnet Clinic, San Francisco AIDS Foundation, and this is a large sexual health clinic located in the Castro neighborhood, greater than 8,000 clients seen annually for sexual health services, about 3,000 active PrEP users. DoxyPep was rolled out in November of 2022. Client-centered advertising in the clinic, social media posts, and the results, that is, were also discussed at all routine PrEP visits. And for anybody who wants to look, the advertising was really spectacular.
Susan, I thought you might flash it.
I did. in the interest of time, I did not. But let's just say they're far more progressive than we are with their advertising.
Well, maybe maybe I'll throw a link in there and people can go.
Yeah, feel free.
Themselves.
I loved it. So and the goal was here the planned evaluation of STI incidence among PrEP users following DoxyPep implementation. And so the study population, again, they looked at all active PrEP clients. So I think that was about 3,000 from June of 2022 to 9 of 2023 that were included in this analysis. And then DoxyPep is offered to all PrEP clients at their routine visits starting in November of 2022. And they created 2 exclusive cohorts. So DoxyPep are clients who started DoxyPep anytime after the initiation of the study. Non-DoxyPep are clients who never started DoxyPep during the study period. And then STI incidence is evaluated per quarter, comparing the pre-DoxyPep period here to the post-DoxyPep period, which starts 30 days after DoxyPep initiation, clearly among those who did take it. Incidence rate ratios, we're comparing pre and post-DoxyPep among DoxyPep users. Boy, that's a tongue twister. And controlled interrupted time series using mixed effects Poisson regression. So this is a schematic of the study. So all PrEP users in the pre-DoxyPep period, and then self-selected shared decision-making into 2 exclusive groups, the non-DoxyPep users who in the entire duration of the study did not take DoxyPep, and then this gradual stepwise increase of DoxyPep users over time as they came into clinic and were offered this option. So well-balanced, but actually total PrEP, DoxyPep. So I guess the point here is the DoxyPep uptake was racially and ethnically robust. That is, the percentage of people in all of these different groups, Black, African American, Hispanic, multiracial, et cetera. Some of the numbers were a bit lower, specifically Native Hawaiian, and I think that was it. And this one's very high, but the numbers are very small. So I'm sure the confidence intervals are massive. But this is, I guess the point is reaching the target population. Again, breakdown by cisgender man and transgender women, the majority, but and non-binary. So this is the breakdown of the group. And here is the outcome. So STI incidence among doxy-PEP users. So whoop, did I just advance? No, we're still good. So here is doxy-PEP. Again, dramatic reduction in any STI occurrence versus no doxy-PEP, essentially no change. And the incidence rate ratios for any STI, 58% reduction in any STI, 67% decline in chlamydia, and 78% decline in syphilis. And again, no change, no significant change here in the number of episodes of gonorrhea. So really striking impact on STIs other than gonorrhea. And this is just to sort of illustrate that the people who self-selected to take doxy-PEP were the people who were most appropriate for doxy-PEP. So this is the STI incidence per quarter showing that the pre-doxy-PEP incidence was quite a bit higher than the never doxy-PEP group. And then once they started right here, doxy-PEP, again, the incidence went down so that they were essentially overlapping at the end. But in the setting of, again, shared decision-making and discussion about sexual risk, there was an appropriate uptake of doxy-PEP in this higher risk group. So real-world setting, doxy-PEP uptake was high, reflecting strong demand among potential users. Uptake was high among those with a prior STI, cisgender men, transgender women, and was quite equitable across race and ethnicity, which I think is very impressive. Overall STI incidence declined rapidly after implementation, showing high impact of the intervention in a real-world setting. There was no impact of doxy-PEP on gonorrhea incidence in the pre-post analysis, and the incidence does appear to be declining over time among doxy-PEP users based on the time analysis. And then, the plan now is continued evaluation of uptake, adherence, and impact on STIs under the expanded, again, implementation. So real world setting, quite impressive. It would clearly be great to look at the resistance issue in this population, and hopefully they will, the gonorrhea resistance. So we're moving right along. Okay, so this is Patrick Sullivan's presentation looking at state level PrEP coverage, showing associated larger declines at the population level with greater uptake of PrEP. So this is a dose response study. So background, again, we know pre-exposure prophylaxis approved. Uptake has increased steadily from 2012 when it was approved to 2022. About 360,000 PrEP users in the US in 2022. And then prior analyses have examined the ecological associations of PrEP uptake and trends in new diagnoses through 2017 and found a significant dose response. So this is a larger study with greater duration of follow-up, looking at the impact of PrEP use on reducing new infections as a proxy for, new diagnoses as a proxy for new infections. So the goal was to look at the impact on new infections, potentially modified by the extent to which those who receive PrEP are at risk for HIV infection and how that might be confounded by parallel HIV prevention and treatment interventions. So this is a study of prescription use. So again, what happens in the background is not mostly assessed. So this is state-specific PrEP prescriptions, calculating using commercial data on pharmacy fills and a validated algorithm for PrEP indications. And then compared with public use data sets from AIDSview, which were used for PrEP users, looking at viral suppression, new HIV diagnoses, as I mentioned. That was their proxy for new infections. And then CDC data on people with PrEP indications. PrEP coverage, the number of PrEP users for 100 persons with indications, the estimated annual percent change was calculated as illustrated here, join point trend analysis. And then they did, very importantly, controlled for yearly jurisdiction-specific viral suppression. And they show here the mean PrEP coverage by PrEP quintile, overall estimated annual percent change, so just percent change in the US, diagnoses from 2012 to 2021, change in HIV diagnoses by quintile of PrEP coverage, and the trend for percent change across quintiles of PrEP coverage among states. So shown here in the pale blue is PrEP users. So just PrEP uptake, I already mentioned, has gone up steadily since it was first approved for this indication in 2012. Just worth noting that during the same period, at least this is when more universal lab reporting became available. So this is why we have lab data showing rates of viral suppression between 2017 and 2021, showing that the level of viral suppression, so increase is good, a bit greater proportion of the population is experiencing viral suppression over time. And by similarly, the number of new HIV diagnoses over the entire duration is trending down a wee bit with the expected COVID drop in 2020. So kind of striking, keep in mind the results in the setting of, this is why they controlled for viral suppression, because both of these two factors, we're looking at the impact of PrEP on new HIV diagnoses in the setting of a gradual decline of new diagnoses and a gradual improvement in the level of viral suppression over time. So again, controlled for background levels of viral suppression. This is the main outcome. Mean PrEP coverage by PrEP quintile of use across 50 states between the time period. The highest quintile was about 16% PrEP coverage as compared to the lowest quintile, which was about 5.8%. And the states involved in each of these were not specified, but there's a lot of speculation in which state is which. Hopefully we're over here. And the corresponding annual percent change in HIV diagnoses by state quintile of PrEP. Whoop, come back. Go back. There we go. By quintile of PrEP use. So what you can see here is the percent change in HIV diagnosis rate. Among the lowest quintile, there was actually a modest increase. Note that this is a trend p-value, comparing these groups. Second quintile, third quintile, fourth, and then fifth. So there is a very clear dose response trend from the states that have the lowest PrEP uptake compared to those with the greatest PrEP uptake in terms of the number of new HIV diagnoses, the rate over time. So a really impressive dose response impact. So jurisdictions with higher levels of PrEP coverage experience larger declines in new diagnoses after accounting for, again, viral suppression data. A dose response relationship exists and the magnitude declines in HIV diagnosis. Combined approaches to HIV prevention, including timely diagnosis, availability of effective treatment, clearly play an additive role in realizing the reductions of new transmissions. And in addition to HIV testing and PrEP referral programs, Medicaid expansion and PrEP drug assistance programs have been found to be associated with higher equity in PrEP use, which is clearly critical to maximizing the prevention benefits of PrEP. So again, the speculation clearly is the lowest uptake is the non-Medicaid expansion states. Though again, he did not mention any states. Again, the population-wide. So one of the questions that Patrick raised was looking at this dose response association, and now Nicholas Medland from Australia looked at HIV incidence in users of PrEP, but a whole country analysis. So really an impressive study. So beginning in April 2018, Australia has had a highly accessible and successful government subsidized PrEP program. What would that be like? This program almost exclusively prioritizes gay and bisexual men. There were greater than 70,000 initiations in a population of 25 million, which, you know, he equates to about 1 million by American population size. It can be prescribed by a doctor in any health setting. The copayment is $20 US versus about $5 for eligible people, $20 if they don't meet eligibility criteria. And they get 90 days of PrEP per prescription. And obviously, to reach elimination of transmission, we need to know how effective is PrEP when scaled up over long term, and how do you measure incidence outside of studies, and what do you compare it to? So this was their study. They looked at unique factors, allowing a novel whole of population analysis using prescription data only. So keep in mind all of the limitations that come with this. They have prescription data only. So this is a highly accessible government subsidized program. Greater than 90% are using PrEP are in this program. So that's the PrEP data reflect, the vast majority reflect this PrEP program. They have very high rates of HIV testing in gay and bisexual men who take PrEP, 99% tested in the past year. Also rapid ART uptake, the same subsidy schemes, the same national treatment program. 98% who received a diagnosis of HIV are on ART. So again, really very structured, organized prevention and treatment programs. So they used linked, de-identified government prescription dispensing data only for PrEP and ART to estimate HIV incidence among people who received PrEP in the 5 years from 2018 to March 2023, predictors of HIV acquisition and population effectiveness of PrEP, using only those who received PrEP once, and I'll get to what that means as a comparator. So they use data and quantity supplied to calculate days covered by PrEP between the first prescription and the end of the study, or the imputed date of HIV acquisition, and categorize PrEP usage as, and these are the comparator groups, a single dispensed supply of PrEP. So people in that time period got one prescription worth of PrEP, roughly 90 days, and never again refilled it or took PrEP again. Those that received more than one, but had less than 60% of their days covered, and then those that had greater than or equal to 60% of their days covered by PrEP. They categorized patient and doctor postcode according to published estimated prevalence of gay men in that postal district. And it was about 2%. And PrEP caseload is the number of individual patients each patient's doctor has. Poisson regression to determine incidence rate ratios, and then a whole bunch of sensitivity analyses. And assumed that those with first PrEP in year 1 were all on PrEP already. And then they also looked at excluding those with first PrEP in year 1. So these are the two groups, all people that were dispensed PrEP, and then, well, these are the two outcomes, I should say. All the people dispensed PrEP and the people who were dispensed PrEP who acquired HIV. So there were 207 HIV acquisitions. As he pointed out, the government prevents them from sharing any numbers below 10, so less than or equal to 10 were women, and really just focusing on the significant months of follow-up. This group had longer follow-up than people who were dispensed PrEP. Days, looking across, days off PrEP at the end of study, 430, and days to first PrEP prescription, 125, et cetera. Don't think, these are the big groups, so I want to focus on these. So the 3 study groups were received PrEP once only, 19%, as compared to those who received less than 60% of their days covered, as compared to those who had greater than 60% of their days covered. And really the goal is to look to the right. If you had received only one PrEP prescription, the risk of acquiring HIV was higher, significantly higher than those who took had PrEP coverage greater than 60%, and also quite high in those that had less than 60% coverage. So clearly, again, based on this is true incidence in the setting that they were negative and then seroconverted during the course of the study. I already highlighted that. Looking at the Kaplan-Meier for the 3 study outcomes, single PrEP supply, so this is the proportion who acquired HIV, much higher, significantly higher in the single PrEP arm, the group that had 1 prescription, as opposed to the orange, which is less than 60% of days covered, but multiple refills. And then this is the proportion of people who had greater than greater than or equal to 60% of their days covered. And just to emphasize, large population, large sample size, over 5 years. So using people who received PrEP only once as the comparator, because they were considered at some point to be PrEP eligible, and they had ongoing risk that was contemporaneous. So again, given that all of these data, 90% of these data are among people who are using the government subsidized PrEP program, they had to be eligible to take PrEP. Hence the reason they were able to use this as a comparator group. And using these as a comparator group, the reference range, those that had greater than 60% of their days covered had a reduction in HIV incidence by 79%. Even those who had less than 60% of their days covered had a reduced incidence by 62%. So really, I would argue, staggering population level results. Strengths, high degree of completeness for a whole nation. Weaknesses, prescription data only. The rest is inferred. Many sub-analyses and sensitivity analyses, they make the point, showed very similar results. Limited covariates, they had nothing on behavior. They can't distinguish cis from trans men, women, race, ethnicity, etc. And then it doesn't include, importantly, a very large temporary visa community with known high HIV intersectionality that were not eligible for this program. So there's something they could work on. So conclusion, great news for PrEP programs. Incidence over a median of 39 months is low. Population effectiveness for ongoing use is high. Where we can do better, HIV incidence, again, I didn't show you the data, but the HIV incidence was higher among people receiving HCV treatment, so concurrently infected. Co-infected, likely an intersectionality of sexual risk, given the low rates of injection transmission of HIV in Australia. So again, do we need a longitudinal model of preventive HIV care, looking at those with lower consumption, a mixture of people at low and no risk, and those who are not correctly matching their risk with their PrEP use, trying to identify those for extra support. Young people, those who don't come back for refills, and young people fell out in the group with higher risk. Those that don't come back for refills, and again, those with HCV risk factors might benefit from additional support. And then finally, people who live or see doctors outside of inner urban gay areas. While not statistically significant, there was a trend that urban PrEP users trended towards having a higher rate of new HIV acquisitions. So again, this might be an identifiable group as one needing more support. All right, on time. So next we move to a CDC presentation from Dr. Singh, estimating the lifetime risk of diagnosis of HIV among MSM. This has been done before, so we'll look at the earlier comparison. This study is 2017 to 2021. So lifetime risk, and we'll jump right to the previous study, which is 2010 to 2014, versus this new study, which is 2017 to 2021, which really is meant to illustrate, let's focus. Many people remember the lifetime risk. A higher relative risk is good, meaning you want a lifetime risk, which is low, means that 1 in 3 Black MSM has a lifetime risk of acquiring HIV, as compared to 1 in 15 white MSM lifetime risk. So lower numbers are bad. And the sad part of this study was that the racial and ethnic disparities among MSM populations in terms of lifetime risk persisted pretty notably here. And over time, despite the rollout of PrEP and treatment is prevention, and all of the other wonderful prevention and treatment interventions. So this is a 10-year age conditional risk. So they looked in 10-year bins, one in X over 20 years, 30 years, 40, whoops, come back, 50 years. And so, okay, we're sensitive, don't touch it. No pointer. In the 20-year group, one in 5 Black African Americans, and then as you scan over to 50, one in 34. So again, if you start age at the beginning of the 20-year interval, if you start at a younger age, the lifetime risk is worse, lower, meaning lifetime risk is worse. So if you start the study at HIV diagnosis at 20 years of age versus 50 years of age. So again, the younger people who are diagnosed at a younger age, let's put it that way, who are in the study at a younger age had a greater lifetime risk. So compared to this earlier analysis, overall lifetime risk, I'd argue, has decreased from 1 in 6 to 1 in 7. So, okay, that's something. But in 2017 to 2021, excuse me, disparities persist by race and ethnicity. We all know this, but this is just a striking illustration. Black African Americans, 5 times Asian and white MSM, Hispanic Latino, 3 times Asian and white MSM, Native Hawaiian, other Pacific Islander, 2 times Asian and white, and American Indian and Alaska Native, 1.4 times Asian and white MSM. So in summary, Black African American MSM now a 1 in 3 lifetime risk, Hispanic Latino MSM 1 in 5, Native Hawaiian, other Pacific Islander 1 in 7. So in 2017 to 2021, regardless of race ethnicity, younger MSM were more likely to receive an HIV diagnosis than older MSM. Again, I think data that we're all familiar with, but this just really highlights, to some extent, I would argue, a depressing lack of improvement across the racial and ethnic divide. Okay, I think this is my last presentation. A few discordant, so this looks at testing among individuals diagnosed with HIV in a national cohort of PrEP users. So the goal here was to assess the frequency of discordant HIV antigen, antibody, and RNA test results in both oral and CAB-LA PrEP users using real-world data. So, you know, last year there was a presentation on the Levi syndrome, long-acting early viral inhibition syndrome. So basically people who had false positive or who had basically HIV RNA or antigen antibody results that were discordant in the setting of acute HIV or this Levi syndrome where they were positive, but it took forever, you know, 8-9 months for the test results to become concordant, RNA and antibody concordant. So how often do these, and some of these just ended up being false positive. So at a single time point of testing, how often do we see false positive HIV RNA or antigen antibody test results in this population, oral and CAB-LA PrEP users? So data source Health Verity, I don't know what that is, linked to electronic medical records, laboratory testing, and prescription data. And the goal was to identify people with a PrEP prescriptions, develop a PrEP user cohort with HIV testing information, and then identify discordant HIV antigen, antibody, and RNA testing results, review the laboratory and prescription information for all patients with discordant testing results, and try and discern the false positive antigen, antibody, and RNA test results versus new infections, and identify any of these possible Levi syndromes that have that very, very, very long time to true diagnosis. Okay. So this is the discordant HIV antigen, antibody, RNA testers among PrEP users. So discordance rate, just jump to the bottom, 0.1%, extremely low. So people who tested, there were 2 antigen antibody positive that were RNA negative, so 5 discordant in this group, antigen antibody negative, people that were antibody negative RNA positive, 6 discordant in this group. These are the concordant groups in not highlighted colors. So overall, going either way with antibody positive, RNA negative, or RNA positive, antibody negative, the number of discordant testing was quite low. So they then divided it. There were 8,000 roughly tests in 5,000 roughly oral PrEP users. And 4 tests had this antibody negative, RNA positive discordance. 1 was an HIV diagnosis. 3, they determined to be false positives based on subsequent negative RNA tests. So 1 HIV diagnosis. And then antigen antibody positive, RNA negative. There were 4 tests in 3 patients, and 3 of them were considered inconclusive because of insufficient follow-up. Jumping to the CAB-LA, 931 tests in 439 users. Again, antibody negative, RNA positive, 2 tests in 2 patients. 1 was likely a false positive, 1 inconclusive, and then antibody positive, RNA negative, 1 test, 1 patient. Again, false positive. No cases of Levi syndrome were observed, that people with that long testing tail of inconclusive data. So results overall, if you look at the combined antigen, antibody, and RNA test results and excluded inconclusive cases, they had an RNA test false positive rate of very low, 0.04 in oral users, 0.1 in CAB users, CAB-LA, and then HIV antibody test false positive, no cases in oral PrEP, and again, 0.1% in CAB-LA. So overall, 1 new HIV diagnosis was identified with an RNA test out of about 8,000 using the combined tests in oral PrEP users. So conclusion, discordant HIV antigen antibody RNA test results were rare among PrEP users. The HIV RNA testing, which is currently recommended, is only rarely identified a new HIV diagnosis that would have been delayed by HIV antigen antibody testing alone. No Levi cases. So the question is, how important is it to do RNA testing at the point of clinical interaction? And the take home was that this is a CDC presentation. The CDC will be reviewing current guidelines that call for RNA testing. So I would watch this space, as we say.
Susan, that's
it. Look at me.
That was it? Oh,
yeah.
Great.
Let's stop sharing.
That was that was beautiful.
I talk fast.
There were questions that sort of happened throughout. So I may ask people to just unmute and maybe bring your slides back, because I think we may have to go back into the slides. I just want to make a comment about the last thing you just talked about with the viral load, the
RNA testing,
the discordant tests.
Yes.
I think that was a very exciting study, because I think that the viral loads have been controversial all along, controversial in particular for oral PrEP use. And I think a lot of people have sort of bought it, or at least come around to it, for long-acting injectable. And even this data showed, that might not necessarily, be needed. And it's just the frequency with which it needs to happen.
Exactly.
With people who have busy lives and then busy clinical practices, expecting someone to do every 2-month viral loads at a lab that might make you wait 45 minutes, an hour to get the viral load, very unrealistic. So
I think no cost efficacy done here, but you can sort of guess.
yeah, exactly. Anyway, thank you for showing that one. I will open it up. Nettie, I know you had a few questions. I don't know if you want to
thanks,
start
Joe.
to chat.
Yeah, sure. Susan, that was great. Thank you so much. I was rapidly cutting and pasting and snapshotting. That was all very, very helpful. I really appreciate that. I was wondering, I was trying to learn something from the people who seroconverted in the Australia study, and there was that table that had all the timelines to stopping PrEP, and it's possible that we can't learn anything about those folks, but it would be great to be able to think about who were they, right? Because they were clearly people who had risk, who were on PrEP, who then went off PrEP, which is kind of duh. That's why they were in the seroconversion group. But I was trying to learn something from them, and I couldn't get enough out of the table to see if there was anything to learn from those folks. Did you see anything like that?
No, not really. I got to go back here. So this is Australia, methods here. So who acquired HIV? So yeah, no, I mean, other than there were a few extra slides, again, looking at, but again, this is prescription data only. So, you know, the really the bottom line is, you know, people, the months of follow-up was, well, shorter because they acquired HIV. Days off last PrEP to first ART prescription was long, meaning they got HIV because they weren't taking PrEP for the most part. A median days off PrEP as compared at the end of the study, as compared to this group, which had only 125, though again, not significant. And really, you know, the main thing was proportion of days covered and a higher concessional subsidy. So the people who acquired PrEP, a greater proportion of them were on the subsidy
that means
program.
They had risk. Yeah. So that's like people who had risk, who got lost and were lost for a long time. So I guess that's maybe something we could learn is like, let's not let people get lost, or especially not lost for a very long
let's not
time.
Do that. Yes.
But they were lost for a really long time, right? Not just like a little bit of time, like a really long time. So,
but isn't this what we know? Like, I mean, I'm glad it shows this, but isn't that it's sort of obvious, right? The people.
It absolutely is. It's if you're on PrEP,
it's so hard, right?
Protected.
Yeah. I mean, I think the answer is put trackers in everyone, maybe under their arms.
Oh, you're going to be popular.
I know.
Creepy.
So, you know, I think for me, the notable thing was this is an astonishing effect at greater than 60% days covered. And, you know, again, even less than 60% days coverage, you know, that's a very significant decline. And I think that's clearly we want to learn more about the people who are in this group. But I think this is obviously the take home, and then how do we address the groups who are being left behind.
And then while we're on the Australian data, John O'Brien asks if any data in the study about development of talk about development of resistance in those that seroconverted.
No, unless I listened to it again and I didn't hear it either time. Still possible I missed it, but no, I don't
probably maybe not analyzed yet.
Yeah,
not
There's a lot of data that you can go on to analyze in this study, I hope, but again, for a population level study with good government assistance programs, this is impressive. You should learn something.
Yeah. Nettie also brought up, and this is going to be a hot question, the effect of doxy-pep on the gut microbiome. She didn't bring up antimicrobial resistance, but that was sort of equally hot. Anything notable from your perspective on that you saw or that you'd like to point to? I sort of was messaging.
I didn't see, and if anybody else who was there saw something, I didn't see anything on gut microbiome in the doxy-pep group. You know,
I think everyone talks about it, that this is stuff they're want.
My recollection is that Annie presented some data last year, so I think they're looking, but to be perfectly honest, I don't remember the results. And I think that's the only data that I've seen on gut microbiome.
Yeah, and what I threw in the chat was, you know, an article about doxycycline as post-exposure prophylaxis from Journal of Antimicrobials and Chemotherapy, and there's a section on it, and I think they gather all the current literature, which is really not about doxy-pep, but doxycycline in general. Because this is not a new drug. I think what remains to be seen, and I think very studyable, is people who aren't using it that much. You know, what does it look like for people who are using it infrequently compared to those who are using it frequently? But at least my quick review in this article was that there wasn't that tetracyclines in general may not have a big effect on the microbiome. Anyway, I was just trying to pull this here. And then, of course, people living with HIV, that will look different than people without HIV. It's a very interesting topic, obviously, and one that would be.
Yeah, I mean, I came away from the doxypep studies thinking, A, put it in the water, and then B, don't use it at all. Because it's going
to be somewhere in the middle, right?
Yeah, it's incredibly effective at reducing chlamydia and syphilis. And then the question becomes, at what cost?
Right.
Sort of the emergence of gonorrhea resistance, tetracycline resistance. Already tetracycline not standard of care treatment, but our treatments are really limited for gonorrhea. So I think that's the big concern, is in a population that has a high rate of gonorrhea, 68% in that one study in the past year, are we setting them up to have serious problems?
But again, if that's not the medication we're using to treat it, and we're just
it's not.
Right. Yep. I mean, for me, when I think about it, and I don't, like, I ask patients as part of my counseling, are you someone that has to, like, that gets frequent folliculitis, or, are you taking antibiotics a lot? Have you used doxycycline before? So that's sort of my one-on-one question. And I've yet to have anyone that has said, yes, and that's a big problem, and then we decided to go in a different direction.
Yeah. I mean, when you look at the associated risk of STI and transmission or acquisition, depending on the population, I overall this is good. Right. I just think we need a better understanding of the resistance question, but at the ecological effects, if you will, at a larger level.
Sorry, I was talking so much. All these questions.
You and I had a nice talk.
You want to see, there was a question from Nimish about doxypep. Any of the studies provide any insight into when the 72-hour window of doxypep was taken between those with and without an STI?
Oh, yeah, that's a really good question, Nimish. Again,
I didn't see anything.
I didn't see anything. Again,
you'd have to be you'd have to be reporting it with a like a text message, this is one I was.
And again, my recollection is that the primary analysis on the Annie Lukemeyer study, I think the primary analysis in New England Journal did give the average time, but from the French study, I don't recall that. I mean, they haven't published yet their primary analysis, but I don't recall seeing that.
Yeah. Possible
I missed it.
And then let's end with a bang. So where are we with gonorrhea vaccine development, Susan?
Oh, I know all about that. Yeah, we've got a new vaccine that's coming. No, we've got a ways to go. So where we started, the for CMV, not really looking like a great option. So yeah, I think anybody that wants to go into the field of gonorrhea resistance prevention, vaccine development, we need people there.
All right. Well, it's at the hour. Susan, thank you so much. Lots of praise, even direct praise about you to me. So I got a top-notch presentation for you. We really appreciate this wonderful summary.
Thank you. So and the slides will be available. None of them are mine, so give credit where credit is due. Thank you very much. Bye, everybody.
Bye, everyone. See you next week.